Welcome to Health Talk. Today we have with us Dr. Mark Melcher, Assistant Professor of Surgery in Stanford University School of Medicine. We're going to talk about kidney and liver transplant. He is a transplantation surgeon, and this is in celebration of National Donate a Life Month. And so welcome, Dr. Melcher.
Thank you. Thank you for having me.
So we're going to start off with kidney transplants. Who gets kidney transplants, and why are we interested now?
So patients with renal failure, so kidney failure, get transplants. The most common indications for, or most common causes of renal failure are high blood pressure, diabetes, inflammation of the kidney causing poor filtration, and then there's some congenital causes also.
Now, all these causes lead a person to first seek dialysis. Is that true? Correct.
So through dialysis is the mainstay for end-stage kidney disease, and there's a couple alternatives for dialysis. There's hemodialysis, where the filtration of the blood, and there's something called peritoneal dialysis, where patients get fluid infused into their abdomen, and the dialysis takes place in that situation.
Now, usually for these patients that need dialysis, their quality of life is quite restrained, you know, because they have to check into someplace every other day. Yeah. Correct.
So people who get hemodialysis often have to go to a dialysis center, spend 3 to 4 hours getting dialysis. It's an exhausting process because they're all coming out of dialysis. They're very tired. It's very disruptive to their lives. It's tough to keep a 40-hour-week job doing that.
Now, you have a video you wanted to tell us about. You want to tell us a little bit about that video?
Yes. So this is a video of my wife's grandmother. She is one of the very first people in the country to get dialysis starting in the 1970s, early 1970s, and she was getting home dialysis. So in this video, we see her lying in bed and this large dialysis machine sitting next to her.
It's like about the size of the bed, the dialysis machine.
It is, and it's it's fraught with complications. It's exposed to getting infections.
And it was quite cumbersome.
Quite cumbersome and very disruptive to anybody's life at the time.
So in a way, that probably was the impetus for people to seek a better solution.
Yeah, and people who can get transplant, the quality of life is generally much improved. They can go back to work working 40 hours a week, and they feel much better than being on dialysis. It's not the ups and downs that dialysis has.
Now, I think that we all know there's a wait list for people who need kidney dialysis. Tell us a little bit about that and how one gets off that wait list or what happens.
Right. So there's a national wait list for kidney transplantation. There are about 85,000 people on the list right now, and about 30,000 people are actually added every year. But then people get transplanted and some people come off the list. So the list grows approximately by 5,000 every year.
Now, in the, if you're on the list, and you can be on multiple lists. Correct.
So the lists are regionalized. There's a national list, but then there's lists that are regionalized. And so you sign up at a transplant center in your region, you get put on the national list. But since organs are allocated by region, different regions have different waiting times. So people who have the resources will sometimes get listed in multiple regions of the country. In the Bay Area, it happens to be one of the longest wait times for transplant. If you have a O blood type, the wait list is approximately 8 years long.
Now, when you're like on a list, somebody usually you see your general practitioner who then sends you to a kidney specialist. Then you have to have failed dialysis. Is that true? Or how severe is your condition to get you on or off the wait list?
So the basic condition is that you have end-stage renal disease. So it's not that you fail dialysis. It's that if you're on dialysis and you don't have any of the contraindications for transplants, you can be listed for kidney transplantation. So you get referred by your primary doctor to a kidney doctor for your kidney disease, and then your nephrologist, who's your kidney doctor, will refer you to a transplant center.
And there are like 240 in America.
There are approximately 240 transplant centers.
And Stanford is one.
And Stanford is one. There are 3 in the Bay Area: Stanford, CPMC, and UCSF.
And of the 85,000 people who are on the kidney wait list, 10% are in the Bay Area.
Approximately 10% in the Bay Area, correct.
Now, in a person who is on this list, there's a national computer database as well.
Correct. So there's so like I said, you get registered on the national wait list, but organs are regionalized. In some rare situations, will organs leave the region and go to other regions. So currently, if there's an organ in, for example, New York that is a perfect match with you, you'll get higher priority than everybody else in the country for that organ. But most of the time, organs donated within one region stay within one region.
Now, we want to talk a little bit about liver transplantation as well. That's also in a very exciting area of research and surgical techniques and breakthroughs in medicine and surgery. Now, for this group of people, who gets a liver transplant? Why do they need them?
So there are sort of a couple broad areas for people who get liver transplantation. The first one is liver failure, and the most common causes of liver failure are cirrhosis from hepatitis C or hepatitis B. Alcohol cirrhosis can also lead you to liver failure and is an indication for transplantation. And then the other most common cause is primary liver cancer. So in select cases, transplantation is a good solution for liver cancer.
It has to be a certain type of liver cancer, right? And they cannot have metastatic disease.
Right. It cannot be metastatic liver cancer, and it cannot be liver cancer that's greater than 5 centimeters in size. The outcomes of patients who have larger tumors is not as good as the patients who have smaller tumors, obviously.
And obviously, since giving a liver organ transplant is very precious, it's a rare commodity, you want the outcomes to be very good. So they select the recipients very carefully.
Correct. There's
a MELD score.
Correct. So the way liver allocation is prioritized is based on is an attempt to do it based on how sick you are, and they do that by very objectively using 3 laboratory studies, the common laboratory studies, and you get a score between 1 and 40, and that score is supposed to correlate to what your 3-month survival is at that point. 40 is a very high score. Usually means the expected life expectancy of those patients is perhaps 2 weeks or so only. So the urgency of getting them a liver transplant is much higher than somebody who has a MELD score, for example, less than 15.
Now this is sort of different from kidney transplant prioritization because there are more kidneys available.
That and kidney patients who are on the wait list for kidney transplantation have the alternative of dialysis, while there is no alternative for patients that have liver failure at this point. There is some research ongoing into liver replacement therapies, but there's nothing equivalent to dialysis at this point. So patients on the kidney list, the primary driver of getting them to transplant is how long they've been on the list, while patients that are on the liver list, the primary driver is how sick they are.
So if you're a chronic alcoholic getting cirrhosis, you're only eligible to get a liver transplant if you've been alcohol-free for how long?
So you need to be alcohol-free for 6 months. Often you need to also be in a supportive program, so like AA, for example, because there's a high rate of people who go back to drinking afterwards, and again, that's obviously
bad for the liver.
Bad for the liver, exactly. Right.